This is part two of a two-part lecture for hematopoiesis. If you saw the previous video, I speak about hematopoiesis, or the generation of blood cells. Today we are going to be focusing on the organs specifically meant for hematopoiesis. Like I always say in my lectures, if you're able to do objectives, then you're going to be on a very good path. So hematopoietic tissue is where hematologic cells proliferate, mature, and differentiate. They are not all the same and they do have different characteristics. Some sites are considered primary, while other sites are considered secondary. Primary meaning where they first begin, and secondary means additional. The sites of hematopoiesis will vary throughout human development and will change over time as you age. Hematopoiesis will begin as soon as the 18th day after fertilization and will continue until you die. Age is the reason that I talked about this is because age is an important factor, especially when you're trying to do bone marrow biopsies. Um, if you collect at the wrong site when a patient is not of the certain age, then you're not going to get the sample that you want. Conversely, collecting for the right site will give you better information than it would be to collect from the incorrect site. So this is sort of the general pattern of development for hematopoiesis. Your first hematopoietic organ when you're around 2 weeks gestation is going to be your yolk sac. In this stage, it's called primitive erythropoiesis. Your second organ then becomes the aortic gonad mesonephros, AGM for short. It's around 4 weeks gestation, and this is where definitive erythropoiesis begins. Around your third month, that is where your liver is where your hematopoiesis will primarily occur, though your spleen, kidney, and thymus will start to become a bit more involved. Then finally, and last but not least, the 6 month of gestation and from adulthood onward, your bone marrow is going to be your primary site. Where in which bone specifically will change over time as you age. So in children, it'll be primarily your tibia and femur. In adults, it'll be your hip bones, vertebrae, and sternum. So when I talk about primitive erythropoiesis, it just sort of means that your red cells aren't exactly good at being red cells yet. Um, you have a lot of these nucleated erythrocytes, and like I mentioned in my last lecture, they're not meant to be nucleated. That is capable of expressing embryonic globins, just sort of like a very primitive hemoglobin. It is important because your tissue as you develop requires oxygen. Big thing though is the hemoglobin that's present in the younger cells are really not going to be stable compared to your fetal and adult hemoglobin chains. The AGM, when around that 4 weeks mark, that's going to be your definitive or normal erythropoiesis, where the proper development from starting from hematopoietic stem cells turning into mature red cells will begin. When your liver starts becoming involved, that will become marks the start of your myeloid and lymphoid cell development. And finally, until we move into your bone marrow, which is where it'll develop your white cells, your red cells, and your platelets. Generally, we're going to have a higher count of myeloid cells than we are going to be erythroid cells, with an ME ratio of about 3 to 1. If you like images, I've always recommended this chart for my students. So you can always track to see where the peak of the organ's activity is in regards to hematopoiesis is based on how many months gestation it is. On the right, we have a color-coded skeleton. Depending on how many years you are in, it'll show you where the primary bone is going to be for how many years old you are. For example, if you're about, let's say, up to 20 years old, your tibia and your femur are going to be primary. But once you get into your 50s and your 60s, that's going to primarily be your vertebrae and your pelvis. The bone marrow will be your primary hematopoietic organ when you are an adult, like I mentioned before. This is where all your blood cells are going to be developed, as well as your early stage lymphoid development. Lymphoid cells get to be a little different. Instead of just completing their maturation process in the bone marrow, they will continue to develop in other specialized hematopoietic organs. Based on where they develop, they'll either be categorized, the organ will be categorized as either primary or secondary. Your primary lymphoid tissue will always be considered your bone marrow and your thymus. This is where your lymphoid cells, such as your B, T, and NK cells, will be created. They should be able to recognize antigen, but they haven't learned a specific antigen yet. That state is called naive. In order to develop into a proper functioning lymphoid cell, they need to move into the thymus. The then um when they need to become immunocompetent or just learning the specific antigen, they need to move into the spleen and the lymph nodes. Again, the bone marrow is considered a primary hematopoietic organ. Your bone, therefore, has to be highly vascularized and made up of a lot of connective tissue. That tissue will be categorized into two components. One is your vascular. This is a lot of your arteries and your veins, as well as your stroma cells and your hematopoietic cell. The endothelial is where basically it's the structure that supports the vascular structure. It's where bone remodeling, repair, and growth is done. Though you might see a little bit of stem cells there. Again, your bone marrow is constantly developing new cells. That's sort of its job. Because of that, it's really the vascular system has to be really extensive in the bone marrow in order to help support the bone and generation of new blood cells. The blood will be supplied from your nutrient and your peristitial artery. The nutrient artery will then branch into arterioles, which will then branch into capillaries called sinuses. This is a really nice image to look at. If you're interested in medicine at all, then I would recommend taking this a closer look than what I usually encourage my students. But if you're a lab tech or a medical lab scientist, just understand that this structure generally exists. Precursor red cells and platelets are arranged into distinct clusters or niches within the bone marrow. Your maturing cells should make up about 95% of the cells in your bone marrow, while hematopoietic progenitor cells will make up only about 3% of your total cellularity. Erythroblasts will make up about 25 to 35% of your marrow cells overall and will cluster in sinuses called the erythroblastic islands. Within that erythroblastic island, you'll have a macrophage whose job is to help develop red cells. Not only will they provide growth factors to tell the red cells to keep growing, but they'll also phagocytize any nucleuses or poorly developing RBCs. Leukocyte development will happen near the bone marrow arterioles. And remember that myelogenous cells will only mature, only myelogenous cells will only mature in the bone marrow. The B and T lymphs will migrate elsewhere, usually to the bone marrow, to the thymus, or if you're a B cell, then you'll go from the bone marrow to the spleen or lymph node. Megakaryocytes are large multinucleated cells that are polyploid, which just means they have multiple nucleoli, whose job is just to prevent or to produce platelets as they develop. And what they do is that cytoplasm sheds off into the venous sinuses, and that becomes platelets. Again, if you're a medical student, I would recommend taking this taking a closer look at this than I am going to describe. For most other people who are interested in being lab techs, just understanding that this process exists is good enough. If you haven't already figured out, your bone isn't just made up of entirely of cells. There needs to be space for the bone marrow to help adapt between what it needs, especially as you age over time. So we sort of have two terminology to describe either active or inactive sites of hematopoiesis. Red marrow is the active site of hematopoiesis. Yellow marrow is just fat. It is considered inactive. The changes observed in either volume will help describe if there's any sort of pathologic changes. If your red marrow volume starts decreasing, then your yellow marrow will have to increase, and vice versa. If your red marrow starts increasing, then your yellow marrow will decrease. So the ratio between the yellow marrow and the red marrow is an important terminology to understand. If the bone marrow becomes much more active or has a lot more red marrow, then we call it hyperplastic. It's usually caused due to an increase from excessive proliferation or just general ineffective hematopoiesis as your body's trying to make up for the ineffective hematopoiesis. A lot of this can occur usually due to acute blood loss, chronic anemias, or leukemias. If you have a lot more yellow marrow than you do red marrow, then that means there's less active sites of hematopoiesis. It can occur either due to acquired conditions like getting toxins in your body or red cell aplasia, or it will happen due to congenital conditions like Fanconi's. The degree of hyper or hypoplasia can help describe the severity, etiology, and duration of disease. The stroma describes the supportive connective tissue found in the vascular component of the bone marrow. Its job is to provide environments that will encourage cell proliferation. The stromal cells will also provide cytokines that will regulate cell growth and hematopoiesis. And there's three major types: the macrophages, the reticular cells, and the adipocytes. Reticular cells or fibroblasts will produce fibers that will help hold and support and anchor those sinuses. Macrophages, whose job is to just phagocytize any debris or dysfunctional cells as they grow, while also providing growth cytokines to help stimulate mitosis and proliferation to the surrounding cells. Adipocytes are just fat cells. Um, the picture on the right has a bunch of these white circles. It doesn't mean that nothing is there. That is where the fat is. We just can't really stain fat all that well. Adipocytes are usually inversely proportional to the osteoblast formation. Um, and it helps manipulate the volume of the bone marrow, which sort of determines where active hematopoiesis can take place. The function of the adipocyte is to provide steroids for hematopoiesis regulation and bone formation. As you age, you start to lose a bit more of that red marrow and get that replaced by fat. By determining cellularity, it's really going to be important for any sort of disease associations with cancer, as you either describe things as hyper or hypoplastic. The endosteum also has two major cells located inside of it who sort of have opposing roles. Osteoblasts are giant bone cells whose job is to remodel bone as they secrete like the matrix to help build up bone. In order to do that, they require blood calcium, and that will so when they're active, they will decrease bone calcium. If you're a potential pathologist, they stain alkaline phosphatase positive. And they are considered normal if you see it during a bone marrow biopsy. Osteoclasts are also nicknamed bone macrophages. Their job is to eat up the bone matrix to help increase calcium levels. However, by eating up the bone and the calcium, then that'll decrease bone density. So, all in all, osteoclasts will eat bone to increase blood calcium. Osteoblasts will make bone, and they have to consume blood calcium in order to do so. Both are under regulation from PTH, calcitonin, and vitamin D. This is just a really cool image. Again, if you're a pathologist, you might enjoy this looking at this more than I do, but I'm not a pathologist. So we don't want just cells to just pop up randomly. Um, Environments are meant for one type of cell versus another, and it's also just generally good to be organized. So the bone marrow you'll see is going to be organized into about four general niches: your stem cells, your red cells, your lymphoid, and your megakaryocytic. The stem cell niche is designed to help keep cells safe from oxidative damage while also keeping the cells in G0, and that'll be primarily regulated by your stromal cells and osteoblasts. Your red cells is where your red cells are, and they're located near the bone marrow sinuses. Again, they surround these macrophages who help provide cytokines to tell them to keep growing while also getting rid of RBC waste and poorly developing RBCs. Lymphoid is niches where the B and T lymphocytes are. Immature lymphocytes are closer to the endosteum. More mature lymphocytes are closer to the sinus and dendritic cells. And last but not least, megakaryocytes get to have their own little pocket near the endothelial cells. So, normally, the bone marrow can produce enough blood cells to help meet bodily demands. And the terminology for hematopoiesis that occurs within the bone marrow is just called medullary, but sometimes things just happen. There's sometimes some sort of force or pathology that's causing extra stress to the bone marrow and therefore requires more red cell production somewhere else. This is where extramedullary hematopoiesis occurs, where hematopoiesis occurs in areas outside of the bone marrow. So, remember the stages that I was talking about where we had different hematopoietic organs? Well, they then start to be active again. The liver and the spleen start to take up the bone marrow's job and starts producing their own blood cells. However, they weren't necessarily designed to do that. The bone marrow is great and has a lot of architecture to help support the complexity of developing red cells. Liver and spleen already have their own function, and they don't really need this on top of that. So what happens is that when they start to take up these extra functions, that causes damage to the liver and the spleen, and they also enlarge from the stress. If it's this severe and this damaging enough, it could lead into organ failure. The describing of the enlargement of both the liver and the spleen is called hematomsplenomegaly. The spleen will be located in the upper left quadrant of the abdomen, right underneath the diaphragm in the left of your stomach. It is by far the largest lymphatic organ in your body. It also has the largest collection of lymphocytes and macrophages in your body as well. And the whole function of the spleen is to help recycle RBCs from circulation, helps in foreign antigen recognition, the storage of platelets, and a lot of other immune cell functions. In hematopoiesis specifically, the spleen serves two functions, either to cull or removing old cells from circulation, or pitting, which just means getting rid of abnormal proteins from the cell membrane. And the spleen is considered a secondary lymphoid organ. So within the spleen, they have three different zones: the white pulp, the red pulp, and the marginal pulp. And the spleen also has a huge vascular system, making about 5% of your total cardiac output. The red pulp contains what we call the sinuses and the cords. It's called red because there's a bunch of red cells hanging out in there. Its function of the red pulp is to help cull and pit RBCs as well as storing platelets. So sinuses will contain pockets for venous blood to drain into. Cords are made up of reticular tissue and macrophages that surround the sinuses. This is where your platelets are stored, as well as where the macrophages will remove damaged RBCs from circulation. Again, culling means killing or damaged RBCs. Pitting means getting rid of abnormal membrane conclusions. And these are all done by the splenic macrophages that are inside. Culling is just completely removing. However, pitting just means that you're just getting rid of these weird membrane inclusions. This does not destroy the RBC in the process. By taking a little bite out of the red cells, the RBCs actually end up like getting a little smaller in size. The reason that they get smaller and don't just pop back in a regular form is because RBCs can't make any more phospholipids and proteins. Antibodies and complements that coat the RBCs make it really easy to bind for macrophages. And this whole process of just culling and pitting is part of extravascular hemolysis. So the way that extravascular hemolysis is done is this. So they are culled in the slow circuit of the cords of the red pulp. Basically what happens is the blood enters the slow circuit. The way that we slow the flow down is by forcing plasma out into these fenestrations. The plasma then enters the lymphatic system for it to be used there. And what essentially this does is causes the concentration of the blood to go way up, and that causes it to become thicker and therefore lead to slower blood flow. When that slower blood flow happens, an acidic, hypotonic, and hypoglycemic environment starts to occur. Now, if you're a good red cell, like a healthy red cell, then you should be able to generally cope with an environment like this. But not every red cell can live up to the standards. Red cells won't be able to cope with that stressful environment. So what will happen is they don't actually end up flowing through the slow circuit. Any splenic macrophage that notices any RBCs moving through the slow circuit extremely slowly will destroy the RBCs that don't get to flow through. The red pulp also acts like a reservoir, which means that if we ever get into a huge bleed situation, then it can help release the platelets in order to help stop the bleeding. Only about one third of your circulating platelets are stored in the spleen. However, what happens is sometimes your spleen gets a little big. That's called splenomegaly. When that happens, that can cause increased platelet sequestration, and they might just hold up about 80 to 90% of your total platelets. So the issue is when you're doing a platelet count, then you might notice that there's a decreased platelet count or thrombocytopenia. If it's really severe, then you could perform a splenectomy, which will help platelet levels return to normal levels in about 2 weeks. Um, the only issue is that you don't really get to have that platelet storage anymore when we get rid of your spleen. So splenectomy patients might be at higher risk for bleeding complications. But sort of the thing is that splenomegaly can become really life-threatening. So doctors often have to balance the need between, well, either they risk bleeding or they will die if their organ fails. So we'll take one over the other. The white pulp in the marginal zones contain lines of defense against your bacterial and viral pathogens, and altogether they contain the largest collection of lymphocytes and macrophages in the body. So what happens is that the blood that enters through the spleen, after they pass through the red pulp, will enter the white pulp in the marginal zones. Blood-borne pathogens are then forced in really tight proximity with macrophages, and macrophages can start recognizing cells to see whether or not they are our own or not us. And the splenic white pulp is really important in developing kids. Kids need the help to help mature their maturing cells, and they have really naive immune systems, so they need as much help as they can. Big issues that in kids is that we notice that kids who went under splenectomies do end up having higher mortality rates from infections that would normally be not an issue for most immunocompetent people. The white pulp is just this gray-white zone that's composed of lymphocytes, and its job is to filter out foreign antigens from the blood and plasma. By filtering out foreign antigens from the blood and plasma, it'll help develop the immune response, which is initiated in the white pulp. The white pulp takes about 20% of the spleen by volume, but if there's active infections, then it might take up more space. Many T cells, macrophages, and dendritic cells are located around the central splenic artery, also called the periarterial lymphatic sheath or PALS. B lymphocytes are arranged into lymphoid follicles outside of PALS, and activated B cells will be found in the germinal centers inside of these follicles. The marginal zone surrounds the white pulp, which is made up of this reticular fiber mesh that contains blood vessels, macrophages, and B lymphocytes, and it also helps separate out the red and white pulps. Its job is to help play a role in antigen recognition of foreign antigens and also helps activate the immune system. So again, if you are a medical student, I would recommend learning this a lot more in depth. If you are a lab tech, just understand that this is the general process. So I've been talking a lot of terminology and I just would like to reiterate it again. Hypersplenism just means that you have an overactive spleen. The issue is that your spleen has been compensating for way too long and it's become damaged by underlying diseases, but either way, it's still forced to be very, very active. Any patients with hypersplenism might have CBC results that resemble anemia, leukopenia, and or thrombocytopenia, just due to the impaired function of the hyperspleen or the spleen. Splenomegaly describes the enlargement of the spleen, and when that happens, that will cause the spleen to lose its normal functionality. It'll often be characterized by left quadrant pains, abnormally low platelet counts, and decreased blood volume due to the spleen just holding up everything in there. Again, hypersplenism can be diagnosed by either the presence of anemia, leukopenia, and or thrombocytopenia. You'll also see a hypercellular bone marrow as it's trying to make up for the amount of red cells that are being lost to the spleen. And if you do a physical examination or ultrasound, you might observe splenomegaly. If the spleen is then removed and the peripheral values return back to normal, then hypersplenism has been confirmed. If it's not, then you have bigger issues. But again, usually doctors will take great care to try to confirm all this before they even try to attempt a splenectomy. Hypersplenism is just a general way to describe a condition. It can be caused by either from itself or due to a different disorder. If the disease is emanating from the spleen, then we call it hypersplenism. It's a pretty rare condition, but generally just means that the spleen has just stopped working for some reason. And it'll be usually diagnosed by cytopenia in the peripheral blood. Hypersplenism means that there's some sort of other disorder that impacts the spleen's function. Secondary hypersplenism can result from extramedullary hematopoiesis, inflammation, infection, or blood disorders like sickle cell or autoimmune disorders. It can also happen due to the infiltration of additional cells that aren't meant to be there, like cancer and neoplasms, metabolic byproducts, or toxins. Again, doctors will try to do as much as they can before they have to resort to splenectomy, which is the removal of spleen. Generally, it's to help relieve any maladies associated with hypersplenism. The thing is, though, you're getting rid of an organ. It's not the greatest thing for the quality of your life. You're in place of your spleen, your liver can also assume the role of cutting and pitting, but it's not as good as the spleen was. So what happens is if your spleen has to do it, then you might see a bit more abnormalities found in the peripheral blood smear instead. Splenectomies are generally more common in people who have hereditary or acquired conditions that result in an increased RBC and increased platelet destruction, which are generally anything that destroys red cells. Your thymus. It is a primary lymphoid hematopoietic tissue which is located towards the top of your stern, found by the anterior of your neck. It is generally a bilobed butterfly-shaped organ which is made up of an outer cortex and an inner medulla. The function of the thymus is to allow immature T cells to migrate into here to complete maturation and differentiation. The thymus will shrink as you age, as you go on, and will eventually lose a lot of its original functionality. The thymic cortex is densely packed with a lot of small lymphocytes, cortical epithelial cells, and macrophages. Arterioles will help deliver immature cells into the thymus cortex. The thymic medulla is less cellular and contains more mature thymocytes, as well as medullary epithelial cells and macrophages. Naive T cells must survive the cortex and the medulla by interacting with self and foreign antigen properly, which is presented to them by dendritic cells. And this is where the positive and negative selection for self antigen will occur. Majority of your T cells will die in this process because it's very rigorous, very strict, and are eaten up by the thymic macrophages. And this is again what the architecture generally looks like. The lymph nodes are your secondary lymphatic tissue. This is where that lymphatic fluid that I was talking about earlier drains into, and its job is to actively filter out for foreign antigens. The lymph nodes are generally bean-shaped and found throughout the body. That way, it'll help be able to protect you against foreign antigens and help mount appropriate immune responses. Inside the lymph nodes, they have this structure made up of either the outer cortex or have the outer cortex and the inner medulla. The cortex has B cell follicles that are surrounded by T cells and macrophages. The germinal centers are also generally located in your cortex. This is where those naive B cells will start to develop into active memory B cells. The medulla is where the stimulated and active B cells move from the germinal center. Active B cells here can become either memory cells or plasma cells. Oh, hello. Okay. Sorry, I thought my microphone was acting up there. Your plasma cells are terminal B lymphocytes that will produce antibody directly in the blood vessels or lymphatic fluid. And this is again what the inside of your lymph node looks like. Mucosal associated lymphoid tissue, also known as MALT, is secondary lymphatic tissue. And they are generally organized lymphocytes that are found on your mucosal surfaces. The where we really focus on is the Peyer's patches, which are found in your intestines, and tonsils and adenoids, which are found in your throat. The function of ML for a MALT is to help trap foreign antigens and initiate the immune response to help keep you safe. Any repeat exposures might help lead into chronic inflammation, which is not great, which is why maybe you or a lot of your friends got your tonsils removed when you were young. Lymphadenopathy just describes the enlargement of the lymph nodes, and the causes will include inflammation, prolonged immune response to any sort of infectious agent, any malignancies, or metastatic tumors that might have originated somewhere else. And that is the end of today's lecture.